Hello and welcome to the Clinical Update Podcast, the podcast that brings you thought-provoking clinical education from MIMS Learning that you can fit into your busy life. I'm Sangeeta, medical editor at MIMS Learning, and I have with me today my colleague, medical editor Dawn.
Hi Sangeeta.
In this episode, we're going to talk about those conditions that might differ in their presentation and management depending on skin tone, particularly darker tones of skin. A lot of those conditions might present differently in darker skin compared with lighter skin.
As a quick example, as a white person, if I'm cold, I will develop a bluish purple tone to my skin and my lips might actually appear blue. But as a person of Indian descent, Sangeeta, I don't think that would be such an obvious thing on you that you're cold.
Yeah, I don't think my skin would really turn blue. Even if I was getting deprived of oxygen, I think it would be a lot less obvious because of my skin tone is a lot darker. So presentations can often be subtle in a person of color, and I think building awareness around this will ensure that we have more equitable care.
Yeah, aware of the need to fill a knowledge gap created by a lack of dermatology education around skin of colour. In collaboration with a consultant dermatologist, Dr. Sharon Belmo, MIMS Learning actually ran an award-winning educational campaign on this issue.
Yes, and we will be discussing some of the updated modules from this campaign. I'm really proud to be part of creating educational material that enables greater representation of skin of color in medical education and that empowers clinicians to improve their medical practice. So there is a lot of ground to cover in a single episode. So we're going to focus on skin cancer in darker skin, a type of hair loss, and changes in pigmentation. So let's start with a common problem in afro-textured hair, and that's traction alopecia.
Yeah, so this condition is reversible if it's identified early. Therefore, prompt recognition and management is very important. The name traction alopecia does imply something to do with the force on the hair.
Absolutely. It is caused by pulling forces on the hair that induce sufficient strain on the follicle to uproot the hair prematurely, usually caused by repeated use of certain hairstyling practices or tight head coverings.
So this is something that can affect people of all ages, genders and ethnicities, but is more commonly seen in women of girls of African ancestry because they are more likely to wear hairstyles such as tight braids that can increase the risk of traction alopecia. Clinically, it presents at hair loss at sites where there is the most tension, so at the root of the braid, for example. Therefore, the loss is usually seen around the hairline and the temples. Often there's also pain, papules, pustules, erythema, tenting, which is when sections of the scalp are pulled up like a tent, and dimpling. When the tension is repeatedly applied over a prolonged period of time, there is miniaturization of the hair shafts and eventual hair loss.
Yeah, so you did mention that it is reversible at the early stages. So why does it become irreversible in the later stages?
Okay, so as traction alopecia progresses, scarring takes place, resulting in permanent hair loss. Essentially, the hair can't grow over the scar. The affected areas will then start appearing smooth and shiny with loss of follicle openings. I have referenced braids, but what other hairstyles can lead to this problem?
So other than braids, tight ponytails and buns, cornrows, weaves, wigs and locks, and head coverings may also contribute. So I think what matters is how tightly the styles have been applied and the frequency with which they're used.
Okay, so hair is a sensitive issue, particularly for black women. Certain styles or practices can be tied to social norms, expectations, cultural or community standards, and faith. So this has to be understood and respected when a woman presents with traction alopecia. So if a woman does present with traction alopecia, she should be encouraged to modify or stop the causative hair practices. And she should also be given education on the causes and the potential long-term consequences of traction alopecia to provide motivation and context for the information she is being given.
Agreed. The consultation should involve informing the patient about their long-term and the permanent effect that the tension and constant pull on the hair can have. There might be some cases when the symptoms are not related to traction alopecia. So Dawn, what are some key differentials for it?
Well, there's trichotillomania, which is when a person compulsively pulls out their hair. But this does present differently from traction alopecia. If a person is pulling hair from their head, their hair loss will usually be much more irregular and patchy than someone with traction alopecia. They will also have broken hairs of an equal length and split ends. There's also female pattern hair loss. With this, you do see miniaturization of the hair follicles as you would do in traction alopecia. However, it presents with diffuse hair loss, which is most noticeable with the natural parting and the vertex. And there's also another condition that can cause hair loss in women is frontal fibrosing alopecia, or FFA, which is progressive scarring alopecia. This typically presents in postmenopausal women, but younger women can present with it, and women of African ancestry tend to start to show signs of FFA earlier than women of European ancestry. The author of the module on traction alopecia, Dr. Ole Yemi Bello, notes that both traction alopecia and FFA can affect the frontal hairline and even coexist, so differentiating between the two requires careful history taking and examination. So back to traction alopecia. Other than patient education, what are the other management options?
Corticosteroids, antibiotics, and topical minoxidil are options for medical management.
Okay, so say a woman does have hair loss. She may be wanting advice on camouflage techniques to mask the hair loss. These could include wigs and hairpieces and scalp micropigmentation. However, she should be advised that extensions can be a cause of traction alopecia and should be used carefully. Though obviously, a hairstylist with expertise in afro-textured hair would be much better advised on alternative hairstyles than a medical professional. So traction alopecia, like we've said, commonly affects afro-textured hair. Isn't this type of hair more fragile than other types?
Yeah, it is. So, the British Association of Dermatologists states that the tightly curled and spring like hair, which is what gives it that lovely volume, also makes it more prone to dryness because sebum cannot travel along the length of the hair, unlike it does in straighter hair types. There is research to show that afro-textured hair is more intricate, given it is more prone to forming knots and tangles, and even simply passing a comb through it can cause breakage, and this impacts the management of scalp and hair conditions as well. That brings us nicely on to seborrheic dermatitis. This is a condition that affects the sebaceous areas of the face, scalp, and trunk. The yeast Malassezia is implicated. Can you talk us through the presentation, Dawn?
Yeah, so on the face and the scalp, seborrheic dermatitis appears as erythematous, hypopigmented or hyperpigmented skin and scaly, greasy patches that affects the nasolabial folds, eyebrows, and central forehead, as well as behind the ears. Blurritis can occur. However, erythema or redness is not always easy to visualize in darker skin, and cradle cap, which can indicate seborrheic dermatitis in infants, will not be so apparent in children with skin of color. However, such children will still have erythema, scaling, and hypopigmentation of the affected areas.
Yeah, and the options for managing this condition include topical azoles, topical corticosteroids, topical calcineurin inhibitors, 2% ketoconazole shampoo, selenium sulfide, Capasol, or zinc pyrithione containing shampoos. Our module on hyperpigmentation says that people with afro-textured hair should be advised to avoid everyday shampooing to avoid dryness and breakage. Once weekly is ideal, and treatment should be prescribed with this consideration. Additionally, people with afro-textured hair with this condition should also be asked to avoid using scalp oils and pomades frequently.
I suspect a black woman doesn't need to be advised to avoid daily hair washing, as she probably knows that. As a white woman, my hairdresser told me more than once not to wash my hair every day. Anyway, pityriasis versus colour is another infection which Malassezia yeast is implicated. The condition is characterised by widespread, scaly, hyperpigmented macules of different sizes with fine scale on the face, cheek and trunk.
And management of pityriasis versicolor is usually by using topical creams or shampoos like ketoconazole and miconazole. Oral treatment with itraconazole or fluconazole is used for more widespread disease. The hypopigmented patches may persist even after treatment, but the treatment should only be repeated if the fine scale reappears over the patches.
Patches of hypopigmentation can also occur with vitiligo. In this case, there's complete loss of the melanocytes in the epidermis caused by autoimmune destruction.
Yeah, vitiligo affects people of all ethnicities, but it does appear more striking in darker skin. The social isolation and discrimination that come with vitiligo can cause a big psychological impact on the person with this progressive condition.
Yeah. Managing this usually involves a dermatology referrals for potent topical steroids or topical calcineurin inhibitors, phototherapy, depigmentation or skin grafting. The patient should be screened for autoimmune diseases. Cosmetic camouflage is another option.
And hypopigmentation is also seen in mycosis fungoides. It usually occurs in younger patients and in darker skin types. It presents as poorly defined, irregular, widespread, hypopigmented patches. Mycosis fungoides is the most common form of cutaneous T-cell lymphoma. Early stage mycosis fungoides can be treated with potent topical corticosteroids or phototherapy. Radiotherapy may be considered for thicker plaques or tumors. Hypopigmented mycosis fungoides has a better prognosis than the other subtypes of cutaneous T-cell lymphoma.
With hyperpigmentation generally, the skin has reduced or no melanocytes. A person with this condition is at higher risk of sun damage and may be more vulnerable to skin cancer. However, counterintuitively, studies show that people with vitiligo are at lower risk of skin cancer. One hypothesis for this condition provides protective benefit against sun damage.
And to add to this, while UV radiation is cited as an important risk factor for melanoma in white people, this association in skin of color is a lot less clear. In a systematic review in JAMA Dermatology, it said that the current recommendations promoting UV protection for melanoma prevention in skin of color are not supported by most current studies. That said, even though the incidence of skin cancer is a lot lower in skin of color than in other ethnicities, the morbidity and mortality are disproportionately higher in this population than in white populations.
Yeah, so one study from the US Centers for Disease Control and Prevention found that the 5-year survival rate for melanoma was 66% in Black Americans, which was significantly lower than the rate of 90% seen in white Americans. One of the reasons for this high mortality rate might be because there can be a delay in diagnosing and consequently treating skin cancer in people with darker skin tones. This relates to a lack of awareness among some healthcare professionals that skin cancer can present differently, or it can even occur in people with skin of colour. If they are not identifying skin cancer, it's not being treated, etc.
Let's look at squamous cell carcinoma, or SCC, first. This is the most common skin cancer in African American people and the second most common skin cancer in Caucasian, Asian, and Hispanic people. Risk factors are fair skin, male gender, old age, and a history of SCC, as well as immunosuppression and chronic exposure to UV radiation.
In fair skin, as is well known, SCC occurs predominantly on the sun-exposed areas of the skin, like the face and the ears. However, in skin of colour, SCC occurs predominantly in areas not exposed to the sun, the lower limbs, and the anogenital region. As mentioned, the presentation in people of skin of colour is different. The features can include keratotic brown or black hyperpigmented plaques with thinner hyperpigmented papules often accompanying the primary lesion. The surrounding skin can have a mottled appearance, and the erythema is not a prominent feature.
Basal cell carcinoma, or BCC, is the most common skin cancer in white people. It is a lot less common in people of other ethnicities, and as a result is being predominantly studied in white populations. The main risk factor is cumulative exposure to UV radiation. On white skin, BCC is seen on sun-exposed sites as asymptomatic, translucent, solitary nodules with telangiectasia, central ulceration, and rolled pearly borders.
The telangiectasia and the pearly rolled borders might be difficult to discern in darker skin tones or in a pigmented tumour. This can lead to BCC being misdiagnosed as serotic keratosis, or malignant melanoma. BCC in skin of colour also has a propensity towards multiple tumours and pigmentation compared to white skin.
Let's also quickly look at malignant melanoma. Though it only accounts for 1% of all skin cancer cases, is the cause of 75% of skin cancer deaths. If diagnosed early, it has favorable survival rates, but advanced stage melanoma has a poor prognosis. In skin of color, melanoma occurs more commonly on the palms and soles of feet or under fingers and toenails. And it is more frequently associated with ulceration in this population, which is a poor indicator of survival. The acral lentiginous melanoma subtype is more common in skin of color. It shows up as an irregular dark brown pigmented patch on the palmar, plantar, subungual, and mucosal surfaces.
And as with SCC, the comparison between mortality in black people and that in white people makes for grim reading. A person of colour is 1.5 times more likely to die from melanoma than a white person, according to Melanoma Research Alliance. This is down to a number of reasons, but again, healthcare professionals and patients being unaware of the difference in clinical presentation could lead to delayed diagnosis and treatment.
So, what have we learned today? First, traction alopecia is preventable if clinicians spot the signs of alopecia and address the cause early, before the hair loss becomes permanent. In many cases, the most important task is sensitively educating the patient about modifying hair care practices to prevent permanent scarring. Second, hypopigmentation presents differently in darker skin, and signs like erythema may not be as apparent. The different care needs of afro-textured hair should be taken into consideration when prescribing for seborrheic dermatitis. And finally, the sites and presentation of skin cancer differ in people of color compared to white people. For instance, SECs predominantly present in sun-protected sites in skin of color, and BCCs are often seen with pigmentation. Melanoma is more common on lower extremities in people of color. Thank you for joining me in this discussion today, Dawn. Don't forget that you can claim CPD credits for listening to this podcast. Be sure to go to mimslearning.co.uk to download your certificate and find links to all the learning modules we've discussed today. Join us for another episode next week, in which our colleague Rhiannon will bring us sound bites and news from MIMS Learning Live North. Thanks for listening. We've been the MIMS Learning editorial team, and this episode was produced by Jude Owen. See you next time.